us today. We're going to have our next session here today. We have Dr. Michael Klepser. Klepser?
Don't. Okay, full disclosure, for those of you guys didn't hear, I misspelled my own name on the slide, and you never live that down.
Dr. Klepser is from he did his doctorate in pharmacy at the University of Michigan College of Pharmacy. I won't say the year. He completed a pharmacy practice residency at Detroit Receiving Hospital and the University Health Center and fellowship in infectious diseases at Hartford Hospital in Hartford, Connecticut. He is a professor of pharmacy at Ferris State University since 2001, and prior to joining Ferris, he was an associate professor at the University of Iowa College of Pharmacy. And today he will be presenting on the practical approaches to stewardship in an outpatient setting. So I'll pass it on to you.
All right. I feel like I'm going to start singing, up here. I'm like the wedding singer and you guys are here and going to listen to every word. No, that's not true because you're sitting close to the door. Hey now, wait, before I get started, first of all, how many of you guys are stewardship pharmacists? Physicians? Nurses? How many of you guys just came because there was a free lunch here? You didn't raise your hand. Public health? What are you?
I'm a pharmacist. We haven't started our stewardship
Oh.
right now, so I'm not.
Oh, okay, yeah. So for those of you guys that don't know pharmacists, we are very much detail oriented and we adhere to the rules. So if we don't get that perfect thing, we're not raising our hand. So how many of you guys actually work on an inpatient setting? How many of you guys are involved in outpatient stewardship? Okay, a handful. And I'm going to blow your mind because my next thing is bringing community pharmacists into stewardship as my next hill. So next time, because how many community pharmacists are here right now? In 5 years, I want this joint filled with community pharmacists talking about it, because really, if we're going to impact things, that's where it's going to be. So I've got a number of disclosures, research grants, paid consultants. A lot of these companies you've probably never heard of because they're not your traditional drug manufacturers. I do a lot of work with point of care diagnostic companies, specifically those that are CLIA waived. We put them in clinics and pharmacies and so forth. Objectives today. One of the things I'm going to talk a little bit about, and I know there's another full session on tracking antibiotic use in the outpatient setting, but to be very honest with you, before you do anything else in the outpatient setting, you got to know what antibiotics are being used, and you got to know what's going on at your site so you can tailor your initiatives and track the outcomes. I want you to identify key individuals with whom to engage to establish an outpatient stewardship team and list some of the interventions. And I'm going to talk a little bit about, in my mind, infections in the outpatient setting are different than the inpatient setting. Alan, in the inpatient setting, when you get a patient who's infected, you just kind of find them laying in a bed and you treat them for however many days and you hope they die or go home, right? So it's a pretty linear thing.
Totally
Random. I know, I don't know where they come from. In the outpatient setting, really, I start thinking infections when patients are at their baseline health, because an infectious journey starts and ends at that baseline health. And my goal as a steward is to keep people healthy so they don't need antibiotics. And so we're kind of talking about that as well. So these are data, a lot of which Jeff has probably developed these data, and he's here so he can see if I get all this data right. But, it's amazing, since the mid 1990s, we've started to use programs on the inpatient side to help combat inappropriate use or optimize appropriate use of antibiotics on the inpatient side. However, we know that the majority of antibiotics are not used on the inpatient side. Majority of antibiotics, 60 to 80%, are used in the ambulatory care setting. So it's really cute that we've done all these things for decades and pat ourselves on the back, but yet we've kind of ignored a lot of what's going on, the problem underlying everything. The other thing to appreciate is a lot of the antibiotics that are being used in the outpatient setting are not warranted. They're being used for non-infectious conditions. They're being used for, inappropriate lengths of therapy and doses of, and so forth. So there's a lot of work that needs to be done in this outpatient setting. And, just again, to get an idea of really how big this problem is, 13% of all physician office visits results in the receipt of a prescription for an antibiotic. And this translates into over 150 million antibiotic prescriptions every year. And if you look at the data from Lori Hicks, the group that they've published out, in 2020, there are about 613 oral antibiotic prescriptions per 1,000 census population. And so, a lot of antibiotics. And again, going back to Dr. Linder's data, about 1 in 3 of these are probably not necessary. All right. And so what's going on? Why is this? We're going to explore that a little bit. Also, it's important that, for indications when antibiotics are appropriate and they are prescribed, a lot of the times the antibiotics that we are being prescribed to patients, either because of history of receipt of other antibiotics, unfamiliarity with treatment guidelines, inappropriate allergies, and so forth, a lot of patients do not receive first-line antibiotics. So there's a lot of room to improve or optimize antibiotic therapy as well. And this is probably one of my favorite papers of all time. And again, I feel like I should be letting Jeff, present the data here. But these are looking at patients, who were, prescribed antibiotics on the outpatient side, and we're looking at rates of appropriateness of antibiotic utilization. And what you can see through here is there are a lot of indications across the age spectrum for which we see a lot of inappropriate antibiotic use. Sinusitis for me, first of all, let's not even get talking about sinusitis, differences between acute sinusitis, chronic sinusitis, the definition of that. We all know acute sinusitis probably doesn't necessarily need antibiotics, but who gets to decide when it turns to chronic? And so there's a lot of, discussion around that. But if you look specifically at respiratory tract infections, there's a lot of times when the use of an antibiotic in these populations is not necessary. We know that for a lot of these conditions, viruses play a huge role in the cause of these infections. And among patients, 50% of antibiotic prescriptions for respiratory tract infections may not be warranted. And for other conditions, maybe about 30% of antibiotics, aren't warranted. Finally, I can talk about data besides Jeff's. So these are some of the data that my group put together with the CHARM project. And so we did is we look at antibiotic prescriptions, and in this case, we looked at almost 1.5 million clinic visits that resulted in about 240,000 antibiotic prescriptions. And you can see on the left-hand side under diagnosis what type of infections were being seen. And then we looked at the concordance of antibiotics, so whether or not it was in agreement with published treatment guidelines, or FDA approvals, or clinic guidelines. And then we also looked at, okay, if it was concordant or it was okay to be used, how many of those were dosed concordantly? And I keep saying concordantly because we found out our people don't like to be told that they're inappropriate or doing inappropriate things, especially prescribing. So concordance and non-concordance is a less combative, we found. But overall, we looked at the non-concordant antibiotics overall. About 60% of antibiotics were not concordant with published guidelines. About 53% of those were not dosed appropriately. So that's a huge amount of work that needs to be done. So what's the big deal? I mean, we've made it this far, just kind of like dosing and prescribing the way we want, but we're more sophisticated. We know that the antibiotic that's being used in a patient and in the population contributes to resistance. There's great data from Europe, looking at macrolide use and resistance to Streptococcus pneumoniae. A lot of good longitudinal data looking at patients who are treated in the outpatient setting and then get admitted to the hospital. And not only maybe they're at increased risk for resistant pathogen, but if you know that you came into the hospital, I just admitted you. What's your name?
Jacob.
Jacob, you've just been admitted. What disease you want?
Give me pneumonia.
Okay, you got pneumonia. And so, Dr. Forrest over here, or Dr. Gross, decided that he was going to prescribe you let's say azithromycin in the outpatient setting, and that wasn't, good for you, and you had to go to the hospital. Now you come in and you got this baggage coming along with you. So, and an inpatient, even if you ended up in the ward, I'm probably not going to want to use a macrolide with you because, he gave you the macrolide in the outpatient setting. So that kind of biased what we're going to be able to use in the hospital. So now I got to think about that in the hospital. So not only do I have to treat your pneumonia, but now this maybe is increasing costs because I have to jump to, a bigger, badder gun. And not only the antibiotic costs, but probably the diagnostics associated with it as well. So now I'm going to try a little bit harder to try to figure out, what might be causing your pathogen resistance profiles and stuff like that. Also, on the outpatient setting, I mean, we've all heard the thing, somebody goes to the doctor's office, and the thought, the comments made, well, you probably don't have an infection, but you might. So here's an antibiotic just in case. It's not going to cause any problems. Yeah, they will. They will cause problems. In fact, adverse drug reactions or visits to the emergency department, 1 out of every 5 drug-related emergency room visits, in patients overall is caused by an antibiotic. And that rate even gets higher when you just look at pediatrics. And that's not even just specifically looking at Clostridium infections and other things. So these antibiotics, they're not innocuous. They're not without risk. And then don't even get me started if, you're somebody like me and every morning you wake up, and this is probably a really bad thing to admit, I tell if it's going to be a good day or a bad day and whether or not I can take all my medications in one swallow. You get your handful of medications, but then those drug-drug interactions, are out there. And you don't always think about what's going to be interacting with all those other medications. And, it can put patients at risk. So the outpatient antibiotic use really does impact healthcare systems at every level. And we need to start thinking about that from a team standpoint, especially for those of you that practice on the inpatient side. It's in our best interest to support folks in the outpatient to make sure that things are appropriate and it makes our lives easier on the inpatient side. This is the obligatory, why do we do stupid things slide, okay? And, one of the big things is, why do prescribers give patients antibiotics when they are pretty sure they don't need them? There's always this thing about patient expectations. There's always this belief that, well, the patient's not going to be happy unless they get an antibiotic, okay? False. Most patients, I get sick, I go to the doctor's office, I don't want an antibiotic. What do I want? Yeah, I want to feel better. I want to feel better, and I want to I would like at least the clinician to pretend that they're sympathetic, to me and listen to me. And that's really what we found drives satisfaction, because in some of the pharmacy models that we did, we only gave antibiotics to like 18% of the patients, but patient satisfaction was greater than 95%. It's because we call them back 24 to 48 hours later and go, hey, how you doing? And that all of a sudden is like, boom, blows their mind. Whether you give them an antibiotic or not, as long as you are kind of treating them as a person. And so that's a key thing. Getting prescribers to think that satisfaction is linked with a product is not true. Guidelines. I used to bash my colleagues in medicine, internal medicine, family medicine, for not being up on the guidelines until I practiced in family medicine and internal medicine and realized, hey, do you know there's more than just infectious diseases guidelines? It took me about 6 minutes to figure that one out. I mean, there are guidelines for everything. And you go, well, why aren't you familiar with the guidelines? Because there are literally about 1,200 guidelines out there that I'm supposed to be familiar with. So forgive me if I didn't get, catch up on that most updated one from whatever specialty group you're representing today. And so it's tough, to do that. So maybe there is a little bit of that, but that's maybe not the biggest cause of things. This is one that's a pet peeve of mine, diagnostics. Okay. Historically, we have not used diagnostics well in the outpatient setting. And a lot of the times, either because there was not a lot of faith in those diagnostics or because they didn't fit into workflow. If I have a patient in and, because of the way that I'm seeing patients and I get a diagnostic near the end of my patient encounter, I don't have time to wait to get the results back to prescribe them something before they go home. So I just look in their throat and go, yeah, that's probably strep. Here you go. And we'll show some data later that, hey, you know what? You have a lot better concordant rate of prescribing when you're able to use these diagnostic tests. There is also a provider shortage, and in the clinics that I worked on, this is probably a very horrible thing to say. And, for those, physicians that see patients in practice, they're scheduled, especially in your large practice, you're scheduled to see patients at a fairly brisk clip. I think my first year residents were seeing one patient every 15 minutes. And by the time they got to their second year and their third year, they were seeing a patient every 8 minutes in clinic. That's a lot of pressure, just to keep things moving along. And so maybe just not having, all the time to, cross all of the T's and dot all the I's or whatever that they would want to do. And just so they're not there until 2 o'clock in the morning writing their notes, they try to keep things moving along. There's also the, dismiss and done. And I mentioned how in the pharmacy models that we've had patients getting called back. How many times you go to a provider's office, you see them and you leave and you get a call back from the provider just to see how things went? It usually doesn't happen because right now that's not the way the workflows are meant to be. And so therefore, since we're not following up with the patient, the thought then being that it's easier to give an antibiotic just to make sure. I'm from Michigan. And in Michigan, and you guys might have them here as well, in some of the larger pharmacies, they have free antibiotic programs. And I think they're well-intentioned, to help individuals who couldn't afford antibiotics get good medications. But what happens is prescribers start to learn the free antibiotic programs, and they start to prescribe the antibiotics that they know are free because they believe that's going to help their patients. So unfortunately, then they start to prescribe suboptimal antibiotics for a lot of things just, to meet that de facto formulary. And then there's fear. I mean, again, nobody likes to be wrong, especially when you're dealing with a patient's health. You want to make sure that you're giving and doing everything you can for them. I've got a daughter who's 4 years old. She, has a heart defect, congenital heart defect. I can't imagine the pressure of her pediatrician going in and she's got, inflammation in her throat. And it's like, man, I can't be wrong because if this goes systemic and attacks her heart, this is going to end up poorly. And so, I get that. I get that fear. And so that's where some of the shared decision-making, understanding the risks and the benefits is going to need to take place. All right. Now the why, the who cares. We've, kind of set it up that there's a problem and we kind of understand some of the problems. But as of January 1st, 2020, yes, 3 days before the pandemic started, the Joint Commission approved performance measures for antibiotic stewardship in outpatient clinics that were accredited by JCO. You guys knew all this, right? I know you guys, okay, who did not know there were actually accreditation standards for clinics, outpatient clinics? So most of you, okay, thank you for your honesty. The rest of these people are liars, right? You and I both know it. But that's important because you know what? It really wasn't until there was a little bit of, that stick from JCO, that stuff really started to take off on the inpatient side. And that's probably why now we're having a lot more interest about outpatient stewardship programs. And there's 5 performance measures, that were released. 1, identifying somebody who cares. Okay, so hopefully y'all are here. So you guys might get knighted by your clinics to be the person that cares. You have to set at least 1 annual stewardship goal. Okay, this is not a high hurdle, right? So we can do this. Use evidence-based practice guidelines. Oh man, feeling good about myself. I mean, who doesn't use evidence-based practice guidelines? So far I'm like really, really feeling good about compliance. Provides clinical staff with educational resources. Yes, we do in-services, check. And then you get down to performance measure 5. Collect, analyze, and report data, pertaining to antibiotic stewardship goals, in your antibiotic usage to the leadership. That's where most people have that gap. Okay, data. Where do we get the data? And that's the thing they struggle with because, IT's just growing on trees these days, right? It's so easy to have an IT request. No, it's not. And so this is the key thing. And when you think about it, this right here, the data, is essential to everything you're going to want to do for outpatient stewardship. Because if you don't know where you stand today, how are you going to know what to do? And how are you going to know if it's effective? So this is a key key component and very important. Again, going to the obligatory slides. These are the obligatory core elements for outpatient stewardship that were published by the CDC. You know, they're a lot more streamlined. How many performance measures or core elements are there for inpatient? Are there like 12? I don't even know if there's 12 things I do on a daily basis that I could put on a card. So there's obviously 12 things to do in a hospital to do stewardship. In the outpatient setting, fortunately, we only have 4 that we have to worry about at the moment. 1, we have to get the commitment. 2, we have to have action for policies and practice. 3, here it is again, track and report. And 4, education and expertise. And again, we can do a lot of these things very easily, but it's that track and report that gets people stymied sometimes and how to accomplish that. Years ago now, so these were published back in 2017. The Society of Infectious Diseases Pharmacists started thinking about outpatient stewardship and realized, you know, we don't really know what that looks like. And typically on the inpatient side, you have an ID trained pharmacist and an ID trained physician kind of leading that team. And so we're thinking to ourselves, well, that's great, but those ID trained pharmacists and physicians, they usually practice on the inpatient side. They're not really in the outpatient side. And, you know, for the very smart individuals who practice on the inpatient side, community-acquired pneumonia is really not that sexy. Where are my crabs or carbs or whatever we're calling them, and all these big metallo-beta-lactamase thingies and stuff like that? So we start thinking, okay, what does this look like? And so in these papers, we helped outline what an outpatient stewardship program might look like. Process for developing the program, identifying key stakeholders, identifying means to quantify antibiotic use, outline some activities and interventions. And so these are the key steps that I would say. If you're going to start an outpatient stewardship program at your clinic, number 1, identify the scope. What does that mean? So let's do this. What does outpatient stewardship mean to you? Where does that affect? Who am I targeting? So you're working in, okay, I'm going to start with you because I'm going to pick on you. So you practice where? Okay. And so if I say start a stewardship, outpatient stewardship, what's your focus? Who are you going to have a stewardship program for?
Yeah, I mean, I think getting back to your point about characterizing your own issues, getting your own baseline data, like characterizing where's the opportunity.
But even when you say that, who is your? Is it, how many clinics did your health system have? Or EDs? How many different subspecialties do you have in these clinics? I mean, and so now you start thinking, okay, am I just doing it at one location? Am I doing it across locations? Am I not going to do it in peds because the pediatricians, they're just dealing with other things? So you need your focus. You need to know what this is. You need to know whose perspective as well. Am I doing it from my clinic perspective, a patient perspective, hospital perspective? All the different perspectives are really going to, I mean, honestly, if you want to do it right, we have a global One Health perspective. And it should just be greater than my system. And so, but that's really complicated because now if I start thinking about identifying a team, now I got to start thinking about people outside of my institution. I got to start thinking about insurance companies. I got to start thinking about community pharmacies, veterinarians, everybody else. So you can get scope creep on this really, really quickly. So you got to identify the scope to figure out where you're going with this. Then that'll help you identify the team. Okay, who's going to be working on this? And we'll talk a little bit about, what these people look like. Then once you get this team together, you task them first and foremost, describe what we're doing now. Describe to me how we're using antibiotics. What are the indications? Who's using them? Are we doing it appropriately? And then based off of that, we start thinking about our priorities. So many times it's just easy. It's like, all right, we're going to do a stewardship program. Let's do allergy reconciliation. Well, why'd you pick that? Just because you read it in a journal? Did you pick it because you knew you had a problem with it? If you don't know all these things, you can't start with the initiatives. And then once you have those initiatives, you definitely got to figure out a way to monitor your progress and outcomes. And again, thinking about what is your outcome? Is it, concordance with guidelines? Is it, use of one antibiotic versus another antibiotic? A whole lot of things. I already gave Alan a hard time about the scope of practice. But again, is it a single institution? How many hospitals are there in Chicago? How many different hospitals, health systems, and stuff like that? Star, I'm going to pick on you. You got that many hospitals in one city? And so if you're going to do a stewardship program in the outpatient, do you just do it for your institution and let the rest of them all die in their antibiotic resistant squalor? I mean, that just seems self-serving. But again, if you're really going to make a difference, are you just wanting to make a difference in the prescribing patterns of people, or do you really want to make a difference in outpatient antibiotic use? I don't know. I like the fact that you guys have this conference, and it seems to be more of, we've got a shared, purpose here. Each site, you need a point person, within the organization, but also at the clinic level. You need to have somebody with the passion. You need to have somebody who gives a darn. And then you need to develop a plan for data dissemination among the partners, because nothing's more frustrating to get all excited about something and then don't hear about it for 2.5 years. And you're like, well, I thought I was on the planning group for that. I mentioned that on our inpatient side, we have all these people with all this expertise chasing around the most interesting cases, in the ICUs and everything else. In the clinics, yeah, we have smart people and we have, some resources, but maybe not the same depth of expertise in some of these areas. So when was the last time, anybody saw an infectious diseases trained physician seeing patients with community-acquired pneumonia in the clinic? That's not who you have there. They're usually looking at the very difficult, the HIV patients. They're looking at some of these more complicated patients. So the majority of the patients that we're going to have don't require that level of expertise, but we can still have these core leaders that help us develop initiatives and policies. And then we find translational members that are at the clinic level who can help apply these type of things that we want to do. And, these individuals at the sites, you don't have to have an ID trained physician or pharmacist or nurse at each site doing this. You just have to, again, have somebody with the passion, the excitement, and train them about antibiotic stewardship. You have to give people roles of what they're going to do. You have to give them the ability, to carry out their functions, whether it's, to track the antibiotics, review the reports, or whatever. Somebody needs to have that, assigned to them. And then there needs to be support. I mean, yeah, let's just keep doing more with the limited time we have, right? Everybody's looking for more work, right? No, I don't know how you guys run in Illinois, but usually we complain we're overworked up in Michigan. And so, if I'm going to take on something new, something else has got to give. I need to have something taken off my plate so I have time to do it and do it well. And this is just an example of how this might play out. Maybe the core members for this outpatient stewardship team, maybe these are some of your leaders from your inpatient stewardship program, the physician and the pharmacist, that will help provide guidance. Ideal, not essential. Translational members, this could be, a nurse, a physician, a pharmacist, again, anybody in there. You need to be working with microbiology, as well, because as we get through this stuff, in the inpatient side, you don't prescribe antibiotics, or you don't get them, just keep them on your patients long without having a firm diagnosis. And whether that's identifying, microbial pathogen, doing susceptibility testing, a lot of that may or may not be relevant in the outpatient setting, but you need to get lab involved to figure out what we can do to firm up that diagnosis. Public health members, are important. In the state of Michigan, our public health folks, our state public health department is really into outpatient stewardship. They provide a lot of data. They have access to all of the big databases that you need money for, and provide us reports and stuff like that. So we're working with them. And then IT expertise is really important. Unfortunately, sometimes you're not going to get in, 5 minutes of the IT specialist time. So you have to train, the pharmacy resident or somebody else to generate the reports. But the IT is going to be key. So what do you do with the data? And what type of data do you need? Again, when you're thinking about the inpatient setting, you want data that reflects your practices, your patients yesterday or today in the hospital, right? You want almost real-time data that's specific to your practitioners and your patients. You don't want data to support your stewardship program from one of the other 30 some odd hospitals in Chicago, because people always then go, well, our patients are different. My patients are different. We've got different flora in our hospital. No, you need to get it at your institution down to an actionable level. Okay, and what I mean by actionable is don't just give me just reports that, oh, in this clinic, they prescribed X number of fluoroquinolone doses over a year's period of time. What am I supposed to do with that? It could have been appropriate. I don't know. I don't know what the indications were. I don't know what the patient populations were. I don't know anything. I can't act on those data. I need to find a way to standardize the data. I need to, because, okay, let's think about clinics. I've been into clinics before with maybe 4 practitioners. And these 4 practitioners, they don't have that many patients in their practice, but the patients they do have love them some practitioners. And then patients come in a lot. So if I was just looking at clinic visits, I might look like I have an elevated metric because these patients keep coming in. But in terms of clinic patients, that's going to be different than some of these larger clinics that maybe only get to see their patients, once or twice a year. So we need to find ways to, make sure we're comparing apples and apples, like clinics to like clinics. Okay. Outpatient antibiograms. Any of you guys have an outpatient antibiogram? How do you do that?
It's not robust.
Okay.
You know,
Is that a nice way to say that you wish it was better?
it's probably antiquated. And so
For what indications, where do you get those isolates? Because when I think of my outpatient setting at pneumonia, they never culture community-acquired pneumonia in the outpatient setting. UTI, we rarely ever culture that, but if anything, maybe that's the one thing that we get cultures on. And so I get all these pathogens that are maybe reflective of UTIs from a nursing home, and I'm calling that my outpatient antibiogram. And so I always struggle with that. I mean, hopefully people can do it better, but I just don't know that it's possible.
I think there's room for that.
Okay.
I think that's what they've done for
Yeah.
this sort.
Yeah. And again, sometimes I think that goes for, well, this is what we do in the inpatient setting. We should do this outpatient too. And it's not an all one size fits all. Some of the other outcomes that we can look at, not just antibiotic utilization rates and stuff like that, look at infection control measures, look at immunization rates. Again, this is kind of like jumping the gun, letting my big surprise at the end out of the bag. One of my most impactful, I think, outpatient stewardship initiatives, immunizations. Okay, Jeff, I told you last night, the quote from your paper that I love the most from his, do you guys know what the greatest risk factor is for receiving an antibiotic? Going to the doctor. So if I can keep you healthy and give you, immunizations, I reduce the risk that you might get sick and might have to go see Jeff. Okay, and so and so for me, that is huge, and that is such a low-hanging fruit for us all to do. And then again, looking at system-wide, and this is it starts perking up some of the inpatient folks. Well, now maybe we start looking at things that impact reimbursement on the inpatient side, because when those patients leave the hospital on antibiotics, I want to make sure that I'm following them appropriately on the outpatient side so they're not readmitted. And so how do I use that as an outcome? What about Clostridium difficile or Clostridioides difficile infections? Sorry. What about CDI rates? What about adverse reactions? Why aren't we tracking that more closely as a metric, in institutions, or ER visits, secondary to these types of things? All these things can be impacted by outpatient stewardship programs. So again, that kind of gets back to that perspective as well. Are we just caring about the antibiotic prescription rates? Are we looking at the overall impact? Again, these are just, some ways to track antibiotic use in the outpatient setting. And I'm not going to lie, up until a few years ago, this was not a very refined business. Because again, in the inpatient, okay, now I just can't take my eyes off of these guys over here, the inpatient antibiotic stewards, and thinking, man, you guys have it so darn easy. You guys are the gatekeepers of antibiotics. Nobody gets an antibiotic unless it comes through your people, goes up to the floor, and you track it, you buy it and stuff like that. In the outpatient setting, we got, the prescriber writing the prescription, and then these patients leave and go wherever to get the antibiotic. So it's hard to track, things like that. And so we have to think of how can we collect data to do stuff like that. And then again, how do we standardize it? These are just some typical ways that people historically have looked at collecting antibiotic utilization data. There's a lot of the large population, from the practice surveys, claims data, purchasing data from wholesalers. These are great for getting an idea of population level antibiotic utilization. Okay. Focus here is population level. They're great for looking at national and regional trends. They're horrible for directing your stewardship program because they mean actually nothing to your practice. You cannot implement some sort of initiative and expect to see it reflecting, in those metrics. Not to mention these data might lag, months to years behind. We can look at prescription fill data. Again, that can be really expensive to get, and it can be difficult to get, as well. From my perspective, the data that's probably the most useful are data from your electronic medical records. Okay, they're your data, you own them, so you don't have to pay to get them. You just might have to pay the IT person, but you need to figure out how to extract them, what data fields, and how to analyze them. And that can be a burden on the individual site, if just left to kind of create their own, products. And this is, again, what we did a few years ago with CHARM, which is the collaboration to harmonize antimicrobial registry measures. And the name means absolutely nothing. It was just made a cute little acronym. So it's the CHARM project. And what we do is we work with partner institutions to extract data from their electronic health record. And we collect limited mass data sets. And these are the only data fields, that, we get out. So when we meet with IT people, they go, seriously, that's all you're asking for? And once they write the query, it's done and we get it, fairly rapidly. What we do is we identify an episode of antibiotic use. So, let's say, you came and visited, my clinic over the past couple of years, I pick out every time you had an antibiotic that was prescribed, and that's linked to a date. With that date, I extract all the information around, age, provider, ICD-10 codes, insurance, and stuff like that. So we anchor it to that visit. So we can kind of track things longitudinally, using you as with a mass identifier. We try to, okay, so this is another cat's out of the bag thing. One of the first stewardship initiatives, if you're looking for something easy, get people to tell you why they're using antibiotics. Because, your ability to do something is only as good as the data you have. And if you're sitting there guessing why they prescribed an antibiotic to begin with, that you're just guessing, just tell me that you did it for pneumonia, okay? And so we use that with the ICD-10 codes. We try to link a diagnosis to the episode of antibiotic use. Then what we do is we look at the antibiotics that were being prescribed and we standardize and normalize the data and we report it back out in antibiotic prescriptions per 1,000 clinic visits and clinic patients for the reasons why I talked about earlier. And then from the data, we look at concordance rate. We look to see if the antibiotic that was selected is concordant with published guidelines, with FDA-approved indications, and with any site-specific treatment algorithms. So we want to try to be as robust as we can to give people the benefit of the doubt that they're using antibiotics appropriately. Once we get an indication as to, how the antibiotics, if they're appropriate or not for their use, then we look at creating, and I'll talk a little bit more about this, ways to determine if the dosing was appropriate as well based off the indication. after we give it to my data analyst, then we share a dashboard with each of our sites. And these are fully interactive dashboards. So everything you click on serves as a filter. So I can get on this. There's 6 pages usually to the dashboards, to help people get a handle on their antibiotic utilization. This is the first page that gives you some trends over time. So let me step back for a second. Typically, when we start working with a site, we ask them to give us a year's worth of data. So they have a little bit of historical perspective. Then once the query is written, most of these sites give us data on a monthly basis. And so the data we have is as close to real time as I think we can get at this point in time. All of these things then act as a filter. So I could look at my age bucket down there, the bar graph. Click on 1 to 9-year-olds. If I click on that, everything else changes to reflect data from 1 to 9-year-olds. I can tell what indications were being treated. I can tell what antibiotics were being used. I could tell you who used it. We've got very granular data. So, you guys are saying, there's lots of clinics within your health system. I can tell you by an address level which clinics were using which antibiotics and how. Within each of those addresses, I can tell you what subspecialties were prescribing antibiotics and how. And within those subspecialties, I can tell you which provider. And so we're able to generate provider level type of report cards to share with them, say, hey, look, this is what you're using compared to your peers. I mentioned that we've created a metric. When you look at the data, it's really tough to say, was this dose appropriate? Because there's a lot that goes into dose, right? There's the dose, there's the frequency, and the duration. And to make simultaneous 3-way comparisons in a large data set is very difficult. So we developed a term called the prescribed therapeutic regimen. And essentially all that is a, for those of you pharmacy geeks, it's kind of like the AUC, the area under the concentration versus time curve. And so it's just an overall exposure metric where I just have the prescribed dose times the duration times the frequency to get a numeric value. That's what the patient got. And then I can compare that to recommended therapeutic regimen. So I create a exposure range that's considered appropriate based off of treatment guidelines and whatnot. And once I get the PTR and the RTR, if the PTR, the prescribed regimen for the patient, falls in that recommended range, we consider that concordant. If it falls outside that range, either higher or lower, we call that non-concordant. And then we dive in to those cases to figure out whether it was dose, duration, or frequency that drove that discordance. What we found overall, and just kind of a stepping back, I'm trying to think, I think we've got 9 health systems currently contributing data to CHARM, 8 in Michigan, 1 in Wisconsin, and several other in development partnerships. In the state of Michigan, I think we cover now 65 to 70% of all outpatient antibiotics prescribed in the state on an annual basis. So we got a pretty good handle of what's going on. And what we found is for a lot of the common diagnoses, there's a lot of discordant antibiotic use, unfortunately. Wrong antibiotic dosing regimen, more than 70% of the time. There's some level of discordance. And again, this is another example of what some of the dashboard pages look like. This one, again, is just looking at, some overall utilization trends. You can see here down the corner, we can tell, who's prescribing by what type. So you can get a quick visual to see if your nurse practitioners, physician's assistants, doctors, MDs, DOs, pharmacists, whoever, how they were doing. And we can also break it apart in this, looking at specific antibiotics. For your antibiotics overall, how are things looking? Some of the new iterations of this, we're able to break it down not only by adult and child, but hey, guess what? I just realized that kids aren't all the same. That kids under 1, they're quite different than kids, 10 years of age. So we're breaking it down a little bit more sophisticated, by age range. We're also breaking it down by renal function, as well. So we're getting a little bit more sophisticated. This is looking at specific, we can get down to indications then as well. So here you can see on the diagnosis, you got urinary tract infections as a filter, and then we wanted to look at ciprofloxacin. Okay, ciprofloxacin theoretically, according to the IDSA guidelines, could be used for the treatment of a urinary tract infection. But what we found, in this, so these gauge charts on the bottom, the line where you see average daily dose 500 and average duration 3, that's would be recommended. A dose of 500 milligrams for 3 days. You can see that in the clinics, they're dosing closer to 800 milligrams on average for almost 8 days of therapy. So our discordance with antibiotic use is driven by dose and duration for the fluoroquinolones. Sometimes you look at, let's say Bactrim. The dose is usually relatively good for urinary tract infections, but again, we're treating for much longer periods of time. Sometimes you have the right agent, sometimes you have the right duration, sometimes, so it's really great to be able to kind of cut through things, very granularly to target how you're going to do your interventions. Then what do you do? What do you do with your data? And that's the key, because how do you develop a priority? How do you develop an initiative in an outpatient setting? What I recommend is before you just jump in and say, hey, look, quinolones are being overused, let's fix it, boom, and just have this educational campaign, find out why. Why are they using so many quinolones? Understand the process. Again, I mentioned that in the clinics that I worked at, the prescribers were, scheduled to see patients very, very quickly, every 8 minutes. How can we optimize the entire process to improve antibiotic utilization? So sit down right from the beginning, from the first contact from the patient coming to the clinic, calls nurse triage. Okay, start there and work your way on and try to figure out each step along the way. Okay, and then for each step, identify, okay, do we have a problem here? Let's say for use of diagnostics, underutilized, and then look at a possible reason. And so eventually you can start teasing some of these things out. And so then when you start thinking about what you're going to do, you've got the problem, you got a potential reason, and now you can actually fix it. And maybe for diagnostics, again, maybe because we use them so late in the visit, for something like a strep test or an influenza test or a COVID test, maybe we should be doing those before the patient actually even gets back to the doctor. Maybe when the nurse, processes the patient to, check him into the clinic, based on your symptoms, check. Here, we need to do a strep test for you. And so the doctor's got that information when they see the patient, so they'll know right then and there, hey, guess what? You got these symptoms and you got a positive strep test, so now we can prescribe the medication. These are just the easy things. List the interventions. For each intervention, do that workflow in the process. Establish reasonable timelines for implementation, and make sure everyone has the same expectations. Again, if we're dealing with somebody from an inpatient perspective, and what they really want is to prevent readmissions, and what you really care about is decreasing fluoroquinolone use, maybe you're not on the same page. So making sure all that lines up. And we need to figure out how often are we going to look at this, what happens. I mentioned the CHARM project. We're able to get data from our sites about every month. And it's been really great to hear back from our partners that they said, hey, we started an intervention. We looked at the next, update on the dashboard. We realized we actually went in the wrong direction. So we stopped what we were doing, changed, right then pivoted and corrected things. So the quicker you're able to, make sure what you're doing is appropriate is going to be important. These are some of the low-hanging initiatives. If you're looking to start, you want to, get up to speed with some of the JCO performance measures. One, track and report. That's key. Just, find out which antibiotics are being used, find out who's using them and how you can manage that. One of the biggest initiatives, tell me why you're using the antibiotic. Okay. When we started with a lot of our clinics, over 80% of the time, there were no indications, linked to the antibiotic. So we had to sit there and try to work it out. And when the clinicians went back to their people and said, listen, we can't do anything until you tell us what you're using it for. We get data back, and it went from, 80% no diagnosis to less than 10% no diagnoses. So that turned around quite quickly. Allergy information, very key. Make sure not only you're listing the allergies, but you ask every single time the patient comes in, do you have any new allergies? Create a field as to what those allergies are as well to give you some indication. And then immunizations. Oh yes, immunizations. I'm going to skip these slides because hopefully you guys are smart enough to know that if you prevent somebody from getting an infection, you don't use antibiotics. And so therefore maybe you can help resistance. The thing I loved about this data though, these are the PCV7 data. So my daughter was born in 1999 and one of the first groups to get the PCV. And not only did we see a decreased rate of systemic infections due to the serotypes that were in the vaccine in kids, that bottom slide is looking at decreases in infections in adults. Those vaccines weren't approved for adults, but yet if your kids don't get sick, the parents didn't get sick and have those as well. So this to me was like, look at the power of an immunization. You don't even have to get it, and it helps. Data on immunization. If we have less of the infections, there's less selective pressure. Maybe there's a replacement in serotypes. Our resistance rates decrease. Again, looking at just really how impactful immunizations can be in terms of preventing individuals from getting antibiotics. And what I really want to do is I want to end on this. This is my cycle, okay? This is starting and ending in baseline health. And at each of these points around this, there's things we can be doing for interventions. And baseline health, this is do good things, healthy lifestyles, immunizations, medication adherence. That's going to be key because this is where your patients spend the majority of their life, is at baseline health, and this is where you want them. When they start to feel ill, now we need to try to educate them about, okay, what are the signs and symptoms of infection versus, you just being a hypochondriac, or whatnot. So when do you actually, maybe need to look at additional care? And as far, help people understand which sites are good for internet guidance, because otherwise I enter my symptoms in those internet things all the time. I either have the common cold or cancer every single time. So which of these are good, to go to? Home point of care test. How many of you guys actually like the home COVID test, home influenza test? I love them. I love them because you know what? Now a patient calls up and said, hey, I was at home, the kid was feeling sick, got a positive test. I got something to go on. And you know what? This patient now probably didn't send their kid to school because they've got a test. So it's not the end all be all, but it's a starting point. Once the patients recognize they're ill, then they make a decision to seek care. And we can help them determine where to go get that care. Does everybody need to go to the emergency department? Do people need to go into physicians' offices? So one thing, do you guys know that in the United States, 30 to 40% of adults do not identify a primary care provider? Okay, how many of you guys have a primary care provider? Okay, let's do it this way. How many of you guys don't have one? Okay, and she's the demographic right there. My brother just turned 50 and he finally got a primary care provider. So if she gets sick with something, Liz, where does she go? So there might be a role for, urgent cares or pharmacy-based clinics or home testing and stuff like that. Once we make that diagnosis, whole bunch of things we can do to influence, which antibiotics we're going to be using. At the site of dispensing, the community pharmacist can be helpful as well, especially if we would just get to the point we're actually putting down a diagnosis again on the prescription, because you know what, how I counsel you to take an antibiotic for a sexually transmitted infection might be different than how I would, do it for community-acquired pneumonia. So give people that information. And then that post-encounter care. To me, this is just really key because nothing is going to put your mind at ease more than calling a patient that you just sent home without an antibiotic, calling them back in a few days and going, how are you doing? And that's really going to help them, be happy with their care as well. All right. So with that, I'm going to stop and I'll take some questions. I will say that if you have an interest in learning more about, CHARM, either for your site or whatever, let me know. Happy to talk to you guys about CHARM and see if we can help you guys at your specific institutions, do some tracking and reporting. So with that, no, don't clap yet. Wait till I answer questions. If I fail miserably, then you don't have to take the clapping back. Oh, okay. Man, you guys are rough in Illinois. Yes.
Well, I have, so I work for a university health system.
Why does every town in Illinois have two names? Bloomington, Normal, Champaign, Urbana.
To make us more present.
Okay, anyway.
But we're not, you know, our health system is only an ambulatory facility. And I haven't been there a whole long time. My background is in hospital, antimicrobial stewardship. But I would ask you as now the sort of charge to get more of this into play in a primary care office where there's no reporting, no specific reporting because it's ambulatory. They're not aligned with Joint Commission,
Mhm.
a university health system, and a very healthy population, and all the arguments for not doing so.
Mhm.
So lots of low hanging fruit.
Mhm.
There is. So coming from a hospital background, to me, having a dashboard is key
Mhm.
because that allows you to bring people in and visualize where you're at, how you're progressing, because, and I know our providers are they're very keen on looking at that they came from areas where they had these sorts of tools. So is this program something that can help with something like that? Now, of course, then we are sort of a university system where, you know, they're careful on what they bring in and so forth. So if it's a service, there's a process. But if you were going to describe a just fundamental dashboard,
Mhm.
I mean, I think I can kind of pull things from your slides and things. Do you have any feedback on that sort of thing, on where to get a group like that started? Now, we have what we call a PMT group,
Mhm.
but they don't do a lot in the stewardship
Okay.
area. So that's really my kind of question.
So usually when, we're approached from an institution like yours, it's because somebody was told we need to do something with antibiotic stewardship. And that was kind of like the charge. Or there was somebody like you that maybe had an interest and really didn't know where to go. Because the first time we started pulling data out of here, I mean, yes, 100%, you can do a dashboard like that on your own. But let me tell you, behind the screen there, we did all these ICD-10 buckets. I mean, Jeff, when you ICD-10s, these are the most horrifically invented thing ever, because not only do I have a cellulitis, but I have a cellulitis of the hand, not just the code for the cellulitis of the hand, but cellulitis of the left hand, index finger. I mean, they get really detailed. So you have to learn how to bucket things together. So you get, data that's just not so all over the place.
You asked about antibiotics.
Yeah.
It's strictly urines.
Yeah.
So, that's all they're doing.
Yeah.
I don't, I mean, they have a hospital, but, they're not doing a lot with that.
Yeah. And so for us, I'll get to Jeff here in a second. One of the reasons we started doing this, and this project right now is fully funded by the Michigan Department of Health and Human Services. And they wanted us to offer these services to the hospitals and health systems in Michigan and some people outside of the state to help alleviate some of that, lack of IT support. Because all we really need the IT people to do is just write an initial query and send us the data, and we do everything else. And we get it back, to those folks. And this MDHHS has also asked us to put together statewide dashboards. So we're creating an interactive dashboard looking at the entire state, so we have benchmarking metrics for people to be able to gauge themselves against as well. And so, this is one of those things where you're always looking for the catch. Right now, I can take on more systems, and no cost to the system. And I'm doing because I'm trying to get more data into my system at this point in time, and it's a value service, to other folks.
Yeah, I was just gonna respond. So I've been very focused on sort of the health system level. I'm not sure like when you came in about, but basically this is an ad for the next talk that Dr. Mohammed is going to be giving about doing outpatient stewardship. But it does sort of exist like the health system level, and what Mike has done though is aggregating regional data, which is like next level stuff. But there, it does take up almost. Your question is an ad for the next. You're right on track.
Okay, interesting.
Are you guys the only ones that have, I mean, like Michigan is obviously doing something different than Illinois. We don't have a program like this. I don't know if there's something like this in the works, or are you planning on, I know you said that you can expand, but would you expand with state to state?
Yes. So like I mentioned, we've got folks in Wisconsin. We've talked to folks in Idaho and others. I've also talked to people in Illinois. So this is all outpatient data.
Oh, it is all-
So these are all outpatient clinic data, but it's not only just the clinics, but we also do emergency departments and urgent cares. We've been now working with dental clinics as well. And so really the format's agnostic with respect to the location, as long as we can pull the data. We've also have a couple systems now that are using it to track transitions of care, looking at when antibiotics were being prescribed, in the hospital, and seeing how that transitioned over for like durations of therapy and stuff like that. We're also looking at it from a social determinants of health standpoint, because we collect some of that information to see how those trends play out. So I know that there's other institutions that are developing their own dashboards and stuff like that. Ours is the only one right now that I know of that we've been going out and just looking for additional partners, who are wanting to do it. Like I said, right now, we capture probably about 65 to 70% of all outpatient antibiotics prescribed every year in the state of Michigan.
Have you talked to like the Coronet? So like it's in Chicago, but these are like Corey funded,
Mhm.
and funding's a little tenuous, but these big systems that Corey funded to like aggregate data from multiple health systems. It's way more complicated than what you described here, but they have governance, more complicated than is governance. Have you talked to them?
We have not talked to them yet. I mean, we've talked with Lori's group down at the CDC, and that's actually, I think, how I ended up here. Is I think some of the Illinois Health Department folks heard that, and just wanted to come raise awareness of kind of what we're doing to see if there's individuals who are willing to, either participate in this or, take ownership of something like that, in the state here. But yeah, right now for the last few years, it's just been data. And if you start looking for all the charm publications, yeah, right now they're still being written because we've just been so busy just getting all of the, the backside, stuff put up. But we've had over 25 presentations this year, at meetings. Gosh, and that's another thing. If anybody has a question they want to ask, Jeff, I'm looking at you. Let me know, because I got so much stinking data, with this. It's just incredible. And because we, capture it at such a frequent interval, I can look at, one of the things we're looking at is the amoxicillin shortage. What happened? What was prescribed? So we're able to look in, when this window for the amoxicillin shortage occurs, what were the prescribers prescribing instead? So we're going to go back through and look at a lot of those type of things. And then I can tell you what type of augmentin formulation, if it's 1 to 4, 1 to 8, so a whole lot of, really cool things. I just need questions to dig down, way down. So am I out of time yet?
Yeah.
Okay. So thank you guys very much.